we can always pause and go through it. That was the whole idea, to make this discussion easier to understand the entire process of using an Excelsius GPS machine. So upfront, as you can say, the workflow, before you begin, the workflow can either be, I think a lot of it would be reiterating what has already been discussed throughout the day, is that the workflow is the first thing that you decide for each and individual patient. Today what patient I am going to show is an MIS L34 for a degen listhesis, reducible listhesis, which reduced on positioning. So it's an easier patient to understand, especially if there are people in the hall which are are positive about using this technology in future or purchasing this technology in future. So workflow is the first thing. You decide whether you need a pre-op workflow or an intra-op workflow. So pre-op workflow is primarily based on a CT which is done prior to the patient coming to the theatre. You can plan your things after that, either on your screen in the office, or you can do the planning after an image matching later in the theatre. So in this particular case, we did a pre-op CT scan, and that CT scan has already been ported through the Naviport into the software of the robotic navigation Excelsius GPS machine. So once you do that, the next part comes is planning. So in this case, we are planning it inside the theatre on the screen. As you can see, we have already marked our levels L3, L4. So there is a left and a right, and a left and a right for 3, and left and right for a 4. So you can virtually pick up the screw from the screen and put it on the 3D model of the spine. You will have four sections of the screen. One is coronal, another one is sagittal, another is axial, and then the 3D one. When you finally place it, you can spin it around and see that I am comfortable with the foramina, with the canal, what kind of trajectory I want. A few tips we learned over the last 1.5 years is that you plan your skin incision through the same machine. So it allows you to pull out that ray out and see where your skin incision will come. So it is very important to plan that skin incision, especially if you are planning a tubular interbody fusion later. So you'll have to compromise a little bit, like come a little medial, don't go too lateral to medial trajectory, because you may struggle, or you have to plan another incision through the sheath medially, but then the skin may be a struggle. So these are the tips that you learn as you progress, but it's advisable to have a middle path for your skin incision where you can perform your procedure comfortably. So I would rather say this, I will take 15-20 minutes. So I was allotted like an hour by Ajay, which I don't understand will be long, but I'll try to go through it quickly because it has been repeated since morning. But I would be more than happy to answer any questions, because this is the basics of going through the step and making it feel comfortable and easy for anybody looking what we are going to do. So please stop me wherever or ask me question in between also. It's not a problem, because rather it will make things clearer for everybody. So that's the planning part, and once you have the planning part, we get the end effector onto the robo. So on one hand, the robo is getting ready. On the other hand, the next step would be to get your, I think we did move forward. I think it moved forward. Did it? There was I think we missed the step on how to get your dynamic reference base. So once you have done your planning on one hand, the robo comes. Our OT setup usually is. I'll show you in the next few minutes. The OT setup is usually that the robo is on the head end on one side, and usually the operating surgeon is standing across. So you can use your robotic arm to put in the screw from your side as well as the other side. This is the end effector which goes on top of the robotic arm. The robotic arm has a shoulder and an elbow in a way to allow you those motion areas. And the next step is to
be a sterile one?
The end effector would be a sterile one. But the robo is not. The end effector is sterile, so it's something that, because we jump theaters a lot, means we do nowadays 3 or 4 robotics also in one day, so we jump theaters. So this is the part that goes in for sterilization, while rest of the robo's arm, the shoulder, elbow till the wrist is draped in a sterile drape, and so is the monitor, the screen. The screen can also be draped. That's a choice. If you have your colleagues who can change your planning in the middle, or you want to touch screen, somebody can help you with all the touch buttons, then you may not drape it, which we sometimes choose. But if you want to control it everything yourself while you are scrubbed, you better put on a drape here, and then this becomes sterile. So the next step from after the workflow understanding is that a pre-op CT, which we will do a image later. We verify all the instruments. So the basic instruments involved are like in any other fixation, pedicle fixation. Only the extra tools here are the direct reference base, which will be the core of the entire robotic system here, because it's navigation based. So everything is spatially oriented with distance with respect from dynamic reference base, which is in the iliac crest. The end effector I showed you that's the robotic arm through which the tools will go for screw fixation. And then we have the fluoro fixture, the one which will go on the 2D C arm, because you have to match the image obtained inside the theater to the pre-op CT. And then we have this, if we are doing an intra-op workflow, then there is a 3D C arm that we have. All the power tools. The first tool for drilling a pilot hole is the burr, and that burr is usually 3 mm or 4 mm depending upon which area of the spine you are operating upon. It usually allows only with a fixed guard till 10 mm, but we try to just make a trough initially up to 5 mm to avoid any drilling deeper into the pedicle. Then we have the awl for the MIS system, which is called revolve. We have the drill. And we also have the drivers and the high speed drills and the tap, and that will be sufficient enough for us to proceed and do our pedicle fixation with the help of. So once you have got all these registers, this is the end effector, which has these diodes, the LEDs, which will be picked up by the array of by the camera and the infrared rays. So all these instruments are aligned on the table towards the foot end. The robo is on the head end while the surgeon is across. So once you have verified all your instruments, you can do them one by one. It's similar to doing everything you do in a navigation alone. So I think that's the step which I was talking about. Is the first step is putting these introducers into the initial pin for getting your the dynamic reference base into place. So this is cannulated on top of it so that it can grab the iliac crest and will not move, because this is the key. You don't want this instrument to move during the surgery. So you just push it in. And that's a cannulated hammer. Throw it in. The tool to hammer your dynamic reference base fixation point in the iliac crest. One key is that you try and move it a little away from the iliac crest, a little away from the lumbar spine. Never try to do it this way, because then it will come in the way of the robotic arm when you are putting your lumbar pedicle screws. So another thing which is peculiar to this system is the surveillance marker, I think, which the industry guys have already spoken about. So they are like they are the watch guys, the ED and the CBI. So this one is watching that one and that one is watching this one. So if there is any movement at any juncture, the surveillance marker will let you know that your DRB has moved and you will not be befooled in the surgery. So that's the surveillance marker on the screen. So the key on the monitor is when you insert a tool into the robotic arm, everything has to turn green. So we have to remember that. So those are your check marks. So this is your dynamic reference array which is coming on top. So it has 3 different modularities of placement, and as Dr. Appaji already told, these are the axis, the optical markers on top of it, and the 3 different modularities where you want to keep depending upon the patient's obesity and the ray between the camera and the capturing of these DRB. Then you have the next step is the imaging. This is a 2D imaging with the fiducial on your 2D C arm, the tube. With that fiducial on, all those optical markers are captured and you obtain a good AP and a good lateral image. So you need an AP and a lateral, 2 images. So this part is the only part of radiation during the entire surgery. There is no other radiation in the entire surgery of putting these screws. So usually you can capture, like you can say 1, 2, 3, around 4 levels are easy to capture in one particular shot. So you see that is the fiducial on top of it. So this is the AP and this is the lateral. And the step here which is being done is there is a centroid which you put in the middle of the vertebral body on the true AP shot and the true lateral shot. So when you will move one, the other one will move accordingly. So you try to place them as much central in the vertebral body as you can. Even though nobody knows the value of that I also never understood, and I've attended so many meetings abroad also, that once you match this image to the CT scan image, there is a scoring that you get. See here, 4. So in this particular case, we got a scoring of 4. So I think the best scoring is 9 or 10, something like that. But usually 4 or 5 is good enough. But in patients who are obese, you will see the score will come down. It may be 3, it may be 2 also. But as far as you do a visual matching of the CT image and the 2D, CT and the 2D, and if you think that both the AP and lateral are matching well for each vertebra, so L3 you do AP lateral matching, 2 images, L4 AP lateral matching. So you overlap them, CT and X-ray, CT and X-ray. So if you think the overlap is very good, this score in my experience does not matter. Of course, the industry says the better the score, more are the chances of accuracy. Good question that has been discussed. So one is that you get a true neutral Ferguson view, like a good AP view with a good exposure. Like, of course, we see the poor scoring happening, especially in deformed anatomy or in obese patients or in revision patients. So there is a chance that the scoring would be relatively poor. But we haven't found any clinical difference in what we do. Our accuracy is the same, whether the score is 8 or 6, as far as there is a visual matching. So, yeah.
Degenerative scoliosis or something, so each vertebra you match?
Each vertebra you have to match.
So each vertebra you have to do a proper AP and lateral.
Correct. If you are using a pre-op CT.
Yeah.
If you are using a pre-op CT, or you do an intra-op workflow.
It is not AP lateral, then you need oblique views.
No, that's in the Medtronic. That's the different machine. Here we are doing an AP and a lateral.
But then you won't get true lateral. Or
Yeah.
true AP.
Means that's where the scoring matters, right? If you can't, then you can't. Whatever the best you can.
But still it's accurate.
It's accurate.
Despite this score.
If your matching is okay, then it's accurate. See, I think we showed the matching. So you will have to overlap the image you acquire on the CT image in the robotic software. So you are matching it. So the next step is to, of course, choose the vertebra which you want to instrument. In this particular case, like we chose, I think I will see on the screen, L4 left or L3 left. So we are going with the left. So once you press the foot pedal, the robotic arm will align in the same trajectory, and how much far it will be from the skin will be based on what instrumentation you have selected an MIS revolve, so it will be placing accordingly, the robotic arm will come into that much space. And these we have two different end effectors, so because we run parallel theaters, so one is for open cases and one is for MIS cases. So you can do an open and MIS alternate, one is 15 mm and the other one is 17 mm in diameter. So you can throw your skin incision through this because it's an MIS procedure. You also have the liberty of holding the robo from the wrist, and then you can press and pull it away if you want your skin incisions to be adequate and slanted medially in trajectory with the screw insertion. So following the skin incision, the next step would be a high speed bar. I think the videographer missed on all 4 images, but anyways we understand what we are doing here is you throw your high speed bar in, and this is the real time imaging that you are watching. So you reach whatever you have planned, you reached at the base of it, bar it, and then it will stop, and you keep checking on all views, sagittal, coronal as well as axial. You can also see the 3D view, you can turn it around during the surgery. The next step is the drill, and following that in many MIS procedures what we do is instead of putting the screw in, I think this is a tap, sometimes we don't put in the tap and we just put the awl and then leave a guide wire, because that's the area of decompression or facetectomy and TLIF. So those extenders may come in your way. So on the side of decompression that you want, we prefer to do the.
Screws are not visible when you put.
The screws are visible. Screws are visible. Here is the screw. I think that technology is just the same, irrespective. Any instrument which is verified and navigation is possible, that will be visualized. So if you look on the screen, I wanted to show you here because there was an error here. I think this particular screw we were finding an error, and I actually wanted you to take a note of that. So the plant trajectory is the blue one and is going slightly superior. So we tried to recheck it couple of times, and if you try to force your way in, then it says excessive deflection force. So these, if you look at the screen, all this screen has to turn green. There is a the L4 left is the screw which is selected. The length is 45 millimeters, a polyaxial screw, revolve, everything will be mentioned here, and this is the diameter, this is the surveillance marker which is green, DRB is green, and all tools are green, and this is the revolve driver which is in place, and there is a deflection because we are using some force. So I remember there was a verification issue with the instrument here which we corrected, and immediately thereafter I think we had the right trajectory because the X-ray looked fantastic. And as we have been mentioning since morning, that the haptic feedback is very important, whatever you do. And many a times I have in my experience felt that maybe if the haptic is not correct, something is not right. And more often than not it would be skiving. And if you have that feel, then you can stop the procedure there itself. You can go back to the planning and you can make the trajectory a little more lateral to medial or cranial to caudal, whatever changes you want to make, and then you go and press the foot pedal again, and you will see the robotic arm which was going like this will suddenly realign itself. And once it realigns, you can do the initial creating the trough, the bar part again. Okay, so I think from here on it is only going to repeat the same steps over and over again. Once you put in your screw, you have done the L4, you have to be careful, these are polyaxial. So one tip here is that do not insert your screw all the way, because that will create a torque force, especially in a quality, if a bone quality is very good, you will have a torque force which will move the entire patient. So you go halfway through and then stop, just leave it. The final tightening can be done at the end of the procedure, so there is no need to go all the way. So till the time you are comfortable. All those drills are also 30 mm. So the burr is allowing till 10 mm, the drill is allowing only till 30 mm, so that you don't overshoot. So all these machines have checks in place for you not to commit an error. And I also recommend, like you're doing an MIS procedure, you've done lots of them without the robo, you'll easily make out this is your midline, this is where I'm going. So there cannot be, I saw one X-ray this morning also, somebody showed an X-ray where 2 screws were going in the canal in an MIS procedure and 2 were going way lateral. So the error happened early. There was no respect to our visualization, something. These are the things which we should always keep in mind. We can trust the technology, but we should always be aware of where we are going, especially when it's the first few cases. Most of these errors I've seen people have done is in the early cases. So that's the next one. I think we put screws on one side, and if we have to do an interbody procedure, we will do a so that's the drill, and that's the awl we have used to put the guide wire. So after the bar and the drill, we throw in the awl manually into it, watching it real time, and then throw a guide wire. The guide wire will not be navigated, so of course you won't be able to see it. For that you can keep your thumb that I want to go in another 10 millimeters beyond the tip of my awl, because awl is navigated, all you can see. So we have put one guide wire already on our side where we have to do the decompression. We are now bringing the robo arm again into action for the other one. So sometimes we extend the same incision on the side of decompression to make it one incision in the middle rather than having 2 incisions. So that's another key step, because this is so confirming. So there's a chance that the blood will clot inside, and you can make it wet, clean it, because otherwise it tends to get jammed, and then it requires a lot of force which bends the robotic arm. Actually, the more confirming it is, and even important now, the step which we saw is that the sheath was not cut properly. So my colleague is trying to push it through the sheath, and the patient, more often than not, skiving will happen laterally, because you will push the patient medially. So it's just the 3D orientation in our head that we are pushing the patient, and the patient is rotating to the other side, so you will skive laterally. You will sink easily into the lateral gutter. So very important that you cut your sheath properly here. So this is what I was mentioning. If you put this into the iliac crest like this, it will start obstructing if you have an S1 screw or something like this. So always put these DRB markers away from the lumbar area, even the surveillance. So the first couple of cases when you do, you realize that these are the tiny things that you need to change. Otherwise they'll just consume a lot of time. I think this morning he had already shown the first case took 60 minutes. I remember, like all of us have gone through. I was in Singapore initially when I learnt MIS. Then Mr. Y Moon told me that I took 6 hours to do my MIS TLIF when I came back from California, and his boss SB10 almost threw him out because they have to cancel so many cases because of that. So this happens, like the first case took you 60 minutes and now it will take 10-15 minutes to do your 4, 6, 8 screws. Actually the time for add-on screws up to 4 or 5 levels, same spin will not take much time. It will take the same time. So what happens is that when you press the foot pedal, the robotic arm first comes into the trajectory, which is the correct trajectory, and then it goes down in the same direction in a linear plane, in a 2D plane. And when it is locked, that's when the screen turns green and you check for everything. If you will use too much force, you will get a notification. How they have calibrated it, I don't know, maybe 1 millimeter movement or something. that green becomes yellow, and then if you move more it becomes red. But more important is when you will drill, it will turn red. But you stop the drill, it turns back to green. That means you are correct. But if you drill and it turns red and you stop still red, that means something is not right. So those are the small keys. If it is red, then you have to check back your steps, your planning. You go back to check your planning. Maybe the screw planning is not great. You are skidding.
Where did you find your commonest mistake?
Is the skiving. Commonest is skiving and going lateral. It's this is something I do in every fourth or fifth case, because what happens is you want to plan your skin incision for the interbody, so you're trying to bring your screws instead of like this, a little bit like this, and sometimes your fellow will just plan it and he can make that error of which surface are you landing on. If you're landing on a horizontal flat surface on the sacrum, or if you're landing somewhere higher up as you go L3, 4, maybe a little bit of a problem because facets will be more vertical and you may have a little bit of a slide, and it all depends on the anatomy previously operated. So all those issues are there, but they're usually very easy to solve. Is to just take a moment off, go back to the plan switch and then replan it. Just position it differently and then you come back and then you're okay. While doing that in a multi-level, you have to be wary of the rod placement, because you have already decided a rod placement. So if you are changing, then you have to be wary. Don't change too much if you have already inserted other screws, or if this is your first screw and you're not happy, then you change it and you change others also accordingly. So that's where the 3D image is very helpful, because it's like a virtual thing. You can move around and look at where you are. So that's easy.
You were discussing the other time about the screw head coming and touching the iliac crest.
Yeah,
And
that's a very common thing.
to me when I was
That happens in MIS also, and then we all blame the robo. So it's just only 3-4 days back, one of the cases was my colleague was performing this one and I was in another theater. So I got a call. He said that my screw looks a little off, but the robo planning was okay. So I went back and checked everything. Everything looked okay. I thought for a moment maybe he could have done a little more trajectory of S1 lateral to medial. But what happens is, actually, if you have a high PI or something, the iliac crest would be going like this, and if you want to go into the sacrum and if you make a very lateral to medial entry, you will get stuck with the iliac crest. So those are the cases where you want to go like this. So he made a good end. He was very happy with the planning that he has done, but he said somehow the screw doesn't look the same, because when he was inserting the drill, he was fine, because drill is very narrow. When he was inserting the bar, the drill, the tap, he was fine. When he inserted the screw with the extender, that touched the iliac crest and the screw moved. And then the screw was looking a little more lateral and caudal than what he designed. That's because it was very evident that it hit the iliac crest, and that's how it changed its position. So these are the things, I think, the more you do, you understand, and then your confidence grows rather than blaming the robo's mistake for all these things. So these little things we learn with time. So we did one C1, C2 also. We got our Doro attachment. We are starting on cervical. We haven't done many cervical till now, but we'll be getting onto it very soon. So I'm happy to take any questions here. I will stop this video.
So you put the pedicle screws first, one side K-wires, do the T-lift, and then put the screws and compress.
Correct. Compress or not compress is our choice based on what you want to do. So, but definitely we prefer this way, putting screws on one side and wires on the other side, so that there is an ease of doing decompression. Otherwise,
Never do T-lift before putting on.
less means it's if it is about robotics, then again the same thing, like both the industry guys are saying the same thing. If you do an interbody, then you take a spin after that. So you are using a pre-op CT. What is the chance of highest accuracy of your pedicle channel? The highest accuracy is when you did the CT, the same spine on the table. That's the highest accuracy. So I prefer, if I'm doing MIS, I would rather throw my screws or wires first rather than doing an interbody. If I have to do an interbody, then I will do an interbody first and then I will have to register, and still there is a chance that the accuracy may go down. I have to trust them for the vertebral registration. They say that you move, but couple of experiences I have, I think there is 1 mm or some error is there. It's not the same trajectory. Either the screw is slightly inferior or slightly lateral. There is a change if you do an interbody first and then. But what happens is in robotic planning, you plan right in the center. So it's an owl's eye, like a bullseye, 100 out of 100. So even if you get 80 because of that error, you don't complain.
So one advantage I find with T-lift doing first, the incision can be put slightly lateral for the T-lift and slightly medial for the pedicle screw. And with one incision you can do both. So that's one advantage I find whenever I have done it. But I agree with you. According to the robot, it identifies the body, so even after putting a cage, it should identify the body. So somehow the mind is not very comfortable accepting that fact. I'm sure they are right.
I don't know really, like we have to trust them, but I am happy doing it this way.
Maybe I would say
Your experience, yeah.
No, I don't. I told you, I'm not.
Yeah.
Yeah.
Open.
So maybe my take would be that you do the fluoro after
Putting the interbody.
and then do a registration again. It will be
Yeah, but then-
more time consuming.
But then workflow becomes intra-op. That will take more time because we are very high volume. We have like limited theaters and we have 6 cases in a day. So we are really jumping.
Because the bodies should remain the same if you do the fluoro after the cage also.
If you do a 3D spin after doing anything, then no problem because now it's a new spine for the robo.
I'm saying if you do you are doing a fluoro, right? 2D
2D
fluoro.
fluoro matching with a pre-op CT.
Correct. So if you do whether before cage or after cage, I don't think it should change much.
I have seen the change. That's what I was trying to say. I've seen the change. I've seen that change.
But you are
I still believe that it's not that easy because pre-op CT when it was done, the distance between just imaginary lower end plate of L5 and upper end plate of L2 was this much, or from the iliac crest. It has moved after putting an interbody. We use a lot of expandable T-lift cages. I'll show you some of them like really jack up and they're like 12-degree lordosis and all that. So I am not confident of doing away with a 2D after that, even though I know clinically nothing is going to happen because of the experience, the feel, the haptics, the margin of error that we have, the visualization I can have. It's not going to go outside the pedicle that wrong with an interbody procedure, but still, because whatever you do, interbody expandable cage is in the front, the difference at the pedicle level behind is not going to be that much. But I still feel more accurate is if you get in your wires first or do a 3D spin after doing your interbody, then you use the OAM now. Register now.
does this allow S2A?
Yes, I have done a few. Not a problem at all.
But then you have your chance on the
On the iliac crest, yes. You will see some disturbance, the movement. But then again, see your pin, that the reference pin is quite lateral. So you begin as an S2A. Once you cross the SI joint, that's when it will start wobbling, right? Because it will move, because now you are drilling through the pelvis. But by that time, your trajectory has already gone that much distance. It's not going to change from there. So what I have seen is that there is a wobble and there is a deflection that appears on the screen because the DRB moves when you're drilling inside the pelvis. But you've already gone as long a trajectory which you have planned on a CT. So you are going to be perfect that way, better than anything that you do freehand. I think we are definitely more happy with the robotic S2AI than doing freehand. There were errors. There were errors with freehand. So here you have designed it all the way. So if you have gone 40 mm, it is not going to change its trajectory from there. So they are all okay.
You do CT in the supine body, sir?
Yes, CT in the supine.
Pre-op.
Yes, in the supine.
So you are confident, comfortable?
No problems at all. No problems at
CT
all.
at the end of the procedure?
We did in the initial few cases, especially where we were doing an intra-op spin. but now we don't. One time, second radiation, too much radiation. I don't think so. It will be easy to publish also doing a post-op CT for every patient inside the theatre. It's not going to be easy, not justifiable at all. So, but initial couple of cases we did because for our confidence, and we found like the very matching films with your planning.
Pre-op CT and intra-op 2D, I think that has been now proven. Yeah, it is accurate. I don't think there is
You have your own MRI scan. You can
Yeah, we
post
have.
op MRI scan.
Yeah, we do that. We do the second spin with the low dose
No, post op MRI. I'm asking you for a
comparison.
pre-op, per-op, whatever you have got,
Yeah.
and confirm with the post-op MRI.
Yeah, we do post-op MRI in certain patients when they have a lot of complaint, but not in all. But all the myelopathy, they go for post-op MRI.
Now, even for the bone, there are these osteo sequences, BTFT sequences, which are giving good bone indication.
Yeah.
No, but the pre-op CT and intra-op, the position is prone,
Yeah.
especially in listhesis and all, it will not make a difference.
It will make a difference.
It will make a minor difference, but we have not seen any significant change in what we do.
I don't have experience with this, but the witnesses I had.
There has to be a obvious difference between what you see there and what you see on the table. It's like grade 3 coming to grade 1. That's definitely a red alert to you. But if it is like a marginal 1 mm here and there, then again I am trusting the fact that it may not be perfect, but it will be right. I am not trusting these guys sitting there who says it is a vertebral registration. It may come from 3 to 1, but we are registering the vertebra. I don't trust it. That's what I am trying to say here. I am not confident of that trust that a spondylolisthesis becomes, listhesis comes back, and then you still trust the same CT which you did. I am not happy with that. In that case, I think the way out is to do a registration on table. We have the 3D, you have the OARM, you just register inside the theatre, forget pre-op.
Forget pre-op.
Forget pre-op.
Can you simulate your operation theatre positioning table on a CT scan and do a CT scan for that and then put more or less? For the pre-op, instead of supine, simulate the operation table, do a scan. I'm sure it should be possible.
In that case, also anesthetized patient, if we are thinking about an instant.
Correct, like to bring everything, yeah, means it requires a lot of human resource. One guy, our team has to be here. Yeah, just a study.
Just to confirm what they are saying.
Correct. I think we are not very unhappy, that's why we are not exploring it. But that's a remark of a perfectionist. We want to achieve that. That's why robo. We want it like that.
We are doing next, this coming week, BTFT, MRI, pre-op, intra-op registration and doing the robot. Don't study whether that itself is enough. This intra-op CT or pre-op CT can be eliminated. Because
Only the MRI. Only the MRI.
Only the MRI, BTFT.
So I have done a couple of cases. I think Atul knows them. I've done only with 2D. No CT, nothing. Only 2D fluoro inside the theatre I've done, and they are perfect.
Cuts down the radiation as well.
No CT at all. I've done them.
So
No
there is a
problems.
Study published by Japanese people with MRI and robot.
Yeah, but MRI anyways will not take your images, right?
So that's what BTFT will take. It's just like CT.
Ah.
Maybe with 60% accuracy as clarity as much as the CT.
Correct. So that your software will take it. The Mesorex will take it. Yeah. So then it's a possibility. But see, if you are doing a lumbar TLIF 4-5 and it's something very it's a degen, bad festal arthropathy, that kind of practice, you can just do a 2D fluoro, which visualization is very good. You're not very obese, you won't be able to see anything. Just a 2D fluoro is good enough. That kind of accuracy is there because it's very close to the iliac crest anyways, and it's not moving. Bone density is good, so those patients you can get away with, but cannot be a standard. Cannot be a
Once you
standard.
step down like this, probably you don't need robots. Because
No,
if
no.
you are so good and clear and you have the experience.
No, because the radiation still goes out. the radiation still goes out. You will need those Jamshedis to be epilateral. That thing goes out. The whole idea is radiation number one if you are a high volume center, I think. But in his case, he was always freehand and he moved to robo for accuracy and
No radiation.
no radiation. He didn't want radiation.
I think the whole point that I want to make is it
But-
will over a period of time take away this experience factor.
Yeah.
Yeah,
I think that is safe for everybody
Correct.
who does a spine surgery, whether you are a patient or a doctor.
see,
I
sir,
think which is the best thing that science can give patients and doctors.
That's what a tool is meant to do.
Absolutely. I think there is not a question of whether robot will overtake
Yes.
human beings. We also can become
Standardized, thing.
absolutely standard of care. I think that's what matters.
another thing, see what you are mentioning. Did you see me in the video any place? I was never there. So I'm always in the other theater where some myelopathy or something else I have to do. I'm never here because I can trust anybody on this. It's a standard. The objective protocol is very standard. So this is what I ignore to do personally.
So, sir, you mentioned that you have used 2D images also.
Yes.
So, does system create 3D out of it, like axial images, or it's only AP and lateral?
No, you take an oblique also. You take 3 images. The system will take all 3 and then it will recreate a 3D for you
Out of those 3 images?
out of those 3 images.
And it will give you an axial image?
Correct. You can, no, it will not give you an axial image. It will only give you an AP and lateral which you can plan and you can see the 3D spin. You can put your screws in on the screen and then you will check with the 3D that I am safe.
That means it creates a 3D recon.
It creates a 3D recon. Yes.
But the input is only AP
Lateral and oblique.
image
Yeah.
instead of a complete.
Instead of a
Maybe there is a pre-built model.
Yeah,
that
pre-built.
will be approximating the
Based
Is
on
this-
algorithm, it will construct and give it.
correct. It's a pre-built model.
Sir, in this case, the principle of floating the screws for it would be the same JFCD principle that you used to do it in your medical.
Yeah.
So the same way he plans the screws. So once you see that on the navigation screen, you will see the screw head, and it will be only 2 plates. But because your generation has worked all throughout with that concept, so it's very easy for you to go there. Maybe a new surgeon may find it difficult.
Actually, it happened like that it was also a serendipity for us. We were not prepared for that. We were prepared for a 3D spin, and it was like first 5-6 cases we have done, and then the patient was a little obese, and we don't have the O-arm, we have the Zyme 3D, so it would not spin around the patient with that obesity. If you have to go up down, then the purpose is defeated. It cannot go up down, it has to spin like that. So it didn't happen. So, but I think patient was obese but not obese enough. We did a 2D and then we went ahead and did it. But we realized that it's not a problem at all. With anatomy is very clear, no deformity, nothing, the density is good. These are decent images to do it. Yeah. And everything at the end of the day is your feel. Like I think he does a lot of open. So whatever the robo may see, you feel it right there and you see it also. In MIS you feel but you may not be able to see.
And MIS is a different ball game when you are doing like this.
Yeah.
Anyway, let's conclude.
Yeah,
Thank you.
I'm okay. Yeah, thank you.